Hello everyone and welcome to our presentation on the pathogens of the respiratory system.
The respiratory system can be divided into the upper respiratory tract, comprised of the nasal cavities, the pharynx and the larynx, and the lower respiratory tract, which consists of the trachea bronchi, the bronchioles, and the lung parenchyma. The passages that extend from the nose to the bronchi are considered part of the conducting system, whereas the bronchioles and alveoli are treated as integral parts of the lungs. The primary function in the respiratory system is to replenish the oxygen removed from the blood during metabolic processes and to eliminate the carbon dioxide that is generated by tissue metabolism. The alveoli are only one cell thick and lie right next to a bed of capillaries, and this allows for the perfect environment for gas exchange to occur. The efficiency of gas exchange is dependent on how closely the flow of air in the alveoli or ventilation matches the flow of the blood in the alveolar capillaries or perfusion. A mismatch of ventilation and perfusion is the main reason for impaired gas exchange in diseases of the respiratory system, and when this mismatch is very large, it causes severe respiratory distress.
Gas exchange can be impaired by disease processes in the blood or in the cardiovascular system, as well as by disorders of the respiratory tract. Microbial pathogens are responsible for several diseases of the respiratory tract that cause a decline in ventilation and in gas exchange, and this leads to hypoxia, which is a major complication in animals suffering pneumonia. Hypoxia may also be caused by obstructive lesions in the upper respiratory tract, such as mucus and inflammatory exudate. Perfusion and ventilation provide the two main avenues in which organisms can enter the respiratory system. Another route for pathogens to enter the lungs is through systemic venous return, as blood from the systemic circulation passes through the lungs from the right ventricle to the left ventricle through the pulmonary vein.
Inhalation also exposes the respiratory tract to a large number of microorganisms. Some of these establish complex microflora, both resident and transient microbes in the upper respiratory tract. The composition of this microflora is influenced by the host species and the conditions in which they live. Some bacteria present in the nasal flora are potential pathogens that can cause serious respiratory disease when host defences are compromised. Aerosol contamination of the environment results in exposure of the respiratory tract to potential pathogens. This occurs during epidemics of respiratory diseases or when high numbers of animals share confined space, which is poorly ventilated or unhygienic.
Inhaled air often contains a range of inorganic particles, organic particles, and noxious gases, and these can damage the tissues and facilitate colonisation of the airways by airborne pathogens. In ordinary circumstances, the animal's immune system is able to protect the respiratory system. However, sometimes if the host is immunocompromised, things can go wrong.
So this picture basically summarises the immune defences of the respiratory system that we're going to cover today. Since the respiratory tract is opening to the environment, a number of specialised cells, barriers, proteins and secretions are required to work in collaboration to remove pathogens. For today's presentation, we have broken this down to innate and adaptive immune defences. So starting in the upper respiratory tract and bronchioles, non-specific protection is imparted by the branching structure and the mucociliary blanket overlying the pseudostratified epithelium with tight junctions and the underlying basement membrane. The branching pattern slows down foreign particles so they can be trapped in the blanket of mucus lining the conducting airways, and the cilia can waft the arrested particles back up to be expelled. Tight junctions are the result of special proteins that link the cytoskeletons of adjacent epithelial cells, including connexins, claudins, paranexins, adhesions, and zona occludens. Connexin 43 is particularly critical in the upper respiratory tract, facilitating communication between epithelial cells for the coordination of the calcium-dependent signalling pathways required for ciliary beating. Mus5b and Mus5ac are the most abundant mucins secreted in the airways, responsible for biting pathogens and preventing attachment, colonisation and entry into the underlying epithelial cells, as well as providing anchorage for innate defence proteins. The importance of cilia is highlighted by a disease condition known as primary ciliary dyskinesia, or PCD, wherein a mutation leading to the malformation of cilia causes severe respiratory difficulties and chronic bacterial infections with species such as Staph aureus and Strep pneumoniae. Respiratory epithelial cells also express toll-like receptors and JAK-STAT receptors that can recognise parts of commensals and pathogens and elicit an appropriate immune response via the secretion of cytokines, allowing for more control over secondary signals and potentially damaging inflammatory responses. Activation of toll-like receptors in the nasal mucosa has also been linked with complement activation, which will be discussed later. The basal cells of the epithelium are critical in repair and replacement in the case of trauma, as damage to the epithelium impairs defences and makes the system vulnerable to infection. Throughout the epithelium, there are also goblet, serous, club, and neuroendocrine cells, together with submucosal glands, secreting mucids, fluids, and innate antimicrobial molecules, including defensins, lysozyme, lactoferrin, cathelicidins, and surfactant proteins.
As we move further down into the lower respiratory tract where gas exchange occurs, there is a reduction in cell variability and thinning of the barrier between airways and blood. Approximately 90% of the alveolar region is covered with squamous type 1 alveolar cells that are in close junction with blood vessel endothelial cells. The basement membrane is diminished here as gas exchange occurs across this thin layer. The other 10% comprises cuboidal type 2 alveolar cells that are responsible for secreting the surfactant and several surfactant proteins. ABCA3, SPA, SPB, SPC, and SPT help maintain composition. They also express toll-like receptors for the recognition of pathogen-associated molecular patterns, or PAMPs, and act as a progenitor for type 1 cells in the event of damage or renewal. Surfactant proteins SPA and SPD are also capable of binding PAMPs, such as surface carbohydrates of common respiratory pathogens. Claudins 3, 4, and 18 provide for the tight junctions of alveolar cells and help control permeability at the gas-blood interface. You can see from this image how thin the physical barrier is at this point and the importance of tight regulation. Tubular myelin is a lattice-like lipid protein structure found on the inner surface of the lower respiratory tract that hosts surfactant and other innate proteins, such as lysozymes and SPB, to further facilitate structural integrity, binding of bacterial, viral, and fungal pathogens, and enhanced phagocytosis by alveolar macrophages. In addition to removal of pathogens and debris, alveolar macrophages aid in the removal and recycling of surfactant. Recruitment and differentiation of alveolar macrophages is achieved by the production of GM-CSF by parenchymal cells of the lungs, which activates the receptor and signal transduction pathway, resulting in the upregulation of transcription factors required. Congenital or experimentally induced autoimmunity to GM-CSF has been directly linked to atypical virus and bacterial pulmonary infections. Mast cells found along the respiratory surface are critical in the event of infection, as degranulation of these cells releases several proteolytic, chemotactic, and inflammatory mediators, which destroy the pathogen and stimulate an appropriate immune response. One study showed that when exposed to mycoplasma, mast cell deficient mice developed comparatively greater clinical disease, such as severe bronchitis and pneumonia, than their healthy counterparts. Complement proteins are an integral part to the innate immune response and act to neutralize, opsonize, attract inflammatory cells, and cause cytolysis by the membrane attack complex. Complement also creates an important link between the innate and the adaptive immune response, as specific recognition of bound complement proteins results in activation of lymphocytes and the clearance of immune complexes. Activation of complement requires one of three pathways: the classical, alternate, or lectin pathway, all of which result in the cleavage of protein C3 to components C3a and C3b. This reveals the active site required for the formation of the membrane attack complex, composed of proteins C5, C6, C7, C8, and poly C9. I won't go into detail about the activation of these pathways, but you can see how each bound component acts as a convertase enzyme for the next component and the common end result from this flowchart. The lectin pathway appears particularly important in the respiratory system, as deficiency in the mannose-binding lectin protein has been linked to lower respiratory tract infections. Majority of complement proteins are produced in the liver and exist in plasma through evidence of mRNA in sinonasal epithelial cells, which suggests the production of local complement proteins following infection or hypersensitivity reactions. Several species of bacteria and viruses have adapted to this defense mechanism and have developed ways to hijack complement receptors, avoid opsonization, and survive the membrane attack complex. For example, the common respiratory invader Staph aureus sometimes expresses a special protein, chemotaxis inhibitory protein of Staph aureus, or CHIPS, that specifically impairs neutrophil chemotaxis by C5a. In the event of infection, activation of toll-like receptors, cytokines, and complement anaphylactoxins usually results in the attraction and activation of neutrophils, macrophages, and any other appropriate inflammatory cells to the respiratory surfaces. Phagocytic cells eliminate pathogens, particularly if opsonized by complement proteins or antibodies, and the release of pro-inflammatory cytokines further aids the inflammatory response.
The adaptive immune response in the respiratory tract is unique in that migration of lymphatic molecules occurs in both serum and mucosal systems. This migration facilitates very specific and local stimulation of the adaptive immune response that can protect the entire respiratory tract. An example of this specific yet widespread immune response is by the production of class-switched IgA B cells. These express the homing molecule CCR10 at their surface, allowing them to individually utilize pathways of antigen migration, such as transnasal pathways, to distant effector tissues, such as mucosal epithelium. Once in situ, the chemokine CCL28 that responds to the CCR10 is produced. This elicits the same immune response at both local and distant sites of antigen deposition. Respiratory lymphoid tissue occurs in the tonsils, adenoids, nasopharynx-associated lymphoid tissue, and bronchial-associated lymphoid tissue to different extents depending on the species. In the lower respiratory tract, 10% of bronchioalveolar cells are lymphatic in function. Other adaptive immune functioning cells, such as cytotoxic CD8 T cells, helper CD4 Th1 and Th2 cells, B cells, and antigen-presenting cells are also present and key throughout the entire respiratory tract. Local antibody secretion occurs throughout the upper respiratory tract. In this region, IgA is the predominant antibody covering mucosal surfaces. This form of antibody is derived following a class switch mechanism brought about in the B-cell germinal region of mucosa-associated lymphatic tissue by IgA-associated cytokines consisting of those listed on the slide. Once class-switched, the IgA B cell can be transported through efferent lymph vessels by lipid mediation to the effector tissue, there differentiating into IgA-producing plasma cells. The IgA can then be transported into the lumen and coat epithelial cells as surface IgA. IgA is a key major immune component, namely in areas of delicate epithelial tissue, for example, gas exchange, due to its anti-inflammatory properties. It's suggested that IgA has little to no role in complement activation and is therefore optimal for secretion on these surfaces due to reduced threat to surrounding tissues of damage by inflammatory activity. The tonsils and adenoids are located in the upper respiratory tract and are responsible for an array of antibodies. Tonsillar germinal centres give rise to antigen-producing B cells that produce IgG and IgM at approximately 55 to 72% and 13 to 18% respectively. These centres also house follicular dendritic cells that bind antibody-antigen immune complexes and generate memory B cells. This differentiation from plasma cell to memory B cell follows stimulation of immune response, such as by vaccination, after which another exposure to said antigen will result in a very rapid IgG antibody response being mounted. T cells comprise approximately half of the tonsillar intraepithelial mononuclear cells, of which the majority express TCR gamma delta receptor and are in a 1-to-1 ratio of CD4 to CD8 cells. Micropore cells, M cells, occur at the base of tonsillar crypt cells and are a specific system for the direct transport of antigens across epithelium. These cells have shortened cilia and house a pocket of immunocompetent cells at their basal aspect. Cells such as dendritic cells in these pockets take up the incorporated antigens immediately as they pass through the micropores. Caudal to the tonsils are the adenoids. The main product of adenoid B cell secretions are IgG, 62% of production, followed by IgA and IgM. As previously mentioned, the IgA type 1 produced here is destined for mucosal secretion at designated effector tissues. The adenoids also have a role in cytokine release when detection of viruses or toxoids, such as those by tetanus or diphtheria, occurs. These are predominantly those listed on the slide.
The conducting airways include the trachea, bronchi, and bronchioles. These house the largest proportions of dendritic cells, particularly at the interceptal junctions between adjacent alveolar units in the lower respiratory tract. Here, dendrites extend between adjacent epithelial cells into the lumen, allowing the direct detection of luminal agents by expression of CX3CR1 receptors. These dendritic cells express MHC2 surface molecules and are therefore able to activate CD4 lymphocytes once they have conveyed the peptide form of the detected antigen to naive T cells. In the lower respiratory tract, a more sterile environment is necessary where simple epithelium and a minimum number of differing cell types aid in gas exchange. The small bronchioles house sporadic mucus secreting cells and in some mammals, organised type bronchiole-associated lymphatic tissue. The predominant type of antigen-presenting cells in the lower respiratory tract are believed to be dendritic cells. However, it is possible that alveolar macrophages also play a role here. At the distal aspect of the lungs, antigen sampling and presentation occurs in a regulated surfactant-rich environment, as opposed to the active mucosal sampling environment of the upper respiratory tract. This may lead to slower migration of antigen-presenting cells to bronchiole-associated lymphoid tissue, simply due to the lack of active pathways as mentioned above. Antibody protection in the lung parenchyma relies solely on IgG and monomeric IgA antibodies, due to the lack of secretory IgA systems in this region. Complement, as previously discussed, also involves antibodies to activate the classical pathway. Both IgG and IgM play a role here by recognising the immune complex formation in the classical complement pathway, and as such beginning the cascade. Fc receptors on the antibody facilitate the formation of the antigen-antibody complex by binding to the globular head of the C1 factor, initiating a conformational change in the complex causing autocatalytic activation of C1. To summarise, the respiratory tract utilises both serum and secretory antibodies as part of its adaptive immune response, due to its ability to attach homing molecules to B cells, and therefore specific and localised immune responses can be affected throughout the whole respiratory tract.
The ability of bacterial pathogens to cause infection is dictated by the 4 steps of pathogenesis: exposure, adhesion, invasion, and infection. Some bacteria produce toxins, which aid in causing infections in the respiratory tract. They can be categorised as endo or exotoxins. Endotoxins cause fever, blood pressure changes, inflammation states, and toxic shock disorders. These endotoxins are integral constituents that are released when the microorganism is lysed. Exotoxins enhance the bacteria's ability to colonise the respiratory tract and cause infectious disease. Each exotoxin varies slightly in the structural composition and mode of action. Some examples are up on the slide. This includes Bordetella, which has a dermonecrotic toxin and a tracheocytotoxin to help cause infection. Adhesion factors are molecules on the surface of the bacteria that aid to invade the host cells. The constituents of bovine respiratory disease, which is usually a mix of bacteria such as Pasteurella and Mannheimia, use adhesion factors for rapid attachment and proliferation in respiratory epithelial cells. The mucociliary system of the respiratory tract is a well-developed defense mechanism, and as such, bacteria need to disrupt this system to cause infection. Disruption of the mucociliary escalator will prevent the appropriate production of mucus, causing a dry throat or over-lubricated respiratory tracts. Some pathogenic bacteria use mucus as a target substance to begin infection. The ability of cilia to beat in order to remove unwanted particles from the respiratory tract is imperative in a working mucociliary system. Many bacteria impair this system and cause the cilia to cease beating or beat out of time, allowing an infection to be established. For example, Pseudomonas aeruginosa produces a phenazine, which has an instant effect on the beating of cilia, causing severe issues in the host within hours of transmission. Bacterial infections in the respiratory tract are caused by a combination of factors. Impaired mucociliary clearance, reduced host defences, and tissue damage, most often in the form of epithelial damage, all play a role in establishing an infection. Tissue damage is often caused by a primary agent, such as a virus or mechanical injury, and bacteria will invade as a secondary pathogen. However, many bacteria have ways of damaging host tissues by themselves. We have already discussed toxins, but bacteria also employ other substances to cause damage to their hosts. Enzymes are often produced by pathogens to damage host tissues. Pseudomonas aeruginosa produces proteases which cause tissue necrosis, and elastases which damage the cilia and mitochondria. Pneumolysins from Strep pneumoniae damage respiratory mucosa. Separation of tight junctions between cells allows pathogens to invade through epithelial layers, penetrating deep tissues and causing further inflammation and damage. Pathogens continue to survive in the host by evading or damaging the immune response. Surface structures allow many pathogens to evade phagocytosis, such as Klebsiella, where capsular
polysaccharides inhibit phagocytosis. Pseudomonas forms biofilms so large that phagocytosis is unable to occur. Bordetella uses a host protein called tubulin to enter epithelial cells and evade the host response. Certain pathogens can also prevent fusion of lysosomes. Altering the host immune response is a method of evasion. Upregulation of the immune response can mask the presence of bacteria, and downregulation, such as inactivation of cytokines seen in Streptococcus, allows pathogen survival. Environmental factors that play a significant role in enhancing bacterial virulence include temperature, iron availability, specific nutrient factors, osmolarity, and pH. Young animals are particularly at risk of adverse environmental conditions and other stress factors. The ciliary action of the respiratory tract can be compromised by factors including cold air temperature, uremia, and dehydration. Additionally, hot, dry climatic conditions can also slow the rate of clearance by evaporating the mucus within the tract. Environmental factors such as these compromise the host's ability to prevent invasion of bacterial pathogens and the establishment of infection. Environmental factors often control the expression of virulence genes. For a commensal resident, its pathogenic success is underpinned by its ability to sense varying environmental cues and initiate an appropriate response in upregulating gene expression. Recent studies show that epigenetics plays a role in the regulation of bacterial pathogenesis and environmental factors, responding to internal and external environmental cues, including climate, nutrition, pathogens, and other environmental factors. Bacterial-induced epigenetic changes can compromise host cell function and allow pathogen persistence and increase the risk of disease states. Host factors also play a role in bacterial pathogenesis. For bacteria to establish a respiratory infection, the host immune system must be evaded or eliminated, which is greatly dependent on the innate and adaptive immune responses. Under stressful conditions, the respiratory epithelial surface may become damaged, allowing commensal bacteria to invade and colonize. Stressful conditions may include transport, sale, and weaning. Stress may impair the mucociliary system and impair the immune system, allowing opportunistic bacteria to invade the respiratory tract. The age of the host also plays a role in the development of respiratory illnesses, with younger animals being more prone to disease as they have lower levels of immunity and are more prone to being in crowded situations, increasing the risk of infection. Bordetella bronchoseptica is commonly transmitted in young puppies and is able to evade the host immune system by directly killing phagocytes and disrupting their signaling pathways to delay the recruitment of innate and adaptive immune responses. A stable microbiota in the upper respiratory tract can help prime the host's immune system and provide resistance against colonization. A healthy microbiota can help prevent other bacteria from colonizing by competing for nutrients and adhesion sites, directly antagonizing pathogens whilst also having anti-inflammatory effects. When the microbiota is disrupted, pathogenic bacteria can then invade the respiratory tract.
The four most common methods for obtaining diagnostic samples using aseptic technique for respiratory pathogens includes a nasal swab, a guarded nasopharyngeal swab, a transtracheal wash, or a bronchoalveolar lavage. The use of each technique is highly dependent on the clinical signs presented and the host. Nasal swabbing remains as the most common method for sampling possible respiratory pathogens in clinical practice, being relatively inexpensive and allowing simple collection. Firstly, it is highly recommended that the animal be muzzled and or restrained for the procedure. Be especially careful to ensure that the swab does not extend past the distance of the nasal cavity, possibly causing damage to the surrounding tissues. With a sterile swab and gloves, insert the swab down the nasal cavity, twisting the swab along its axis to minimize mucosal damage as you go, directing upwards and medially as you move from the external nares into the nasal passage. Swab both nasal passages, although the same swab can be used for both, taking care that the patient is restrained to prevent the swab breaking and internal mucosal damage. Take note that a small amount of blood on the swab is normal. Place the swab into a sterile leak-proof container and label. You may need to snap part of the swab off to allow it to fit. Add 1 ml of sterile physiological saline to prevent desiccation. Do not freeze sample, but store on ice at about 4 degrees Celsius and ship to external laboratory with ice packs. Disinfect all involved equipment. Note, there may be difficulty examining samples from nasal swabs due to the contamination by commensal organisms. This is an inherent flaw in this sampling method, and other techniques prove more successful in eliminating this contamination, such as guarded nasopharyngeal swabs.
A nasopharyngeal swab allows the collection of specimens from respiratory mucosa that is a relatively quick and simple procedure. The guarded tip covers the end of the outer sleeve, preventing contamination of the sterile swab. However, this method is less comfortable for patients and has the potential for collecting pathogens that are not the responsible disease-causative organism. In this technique, firstly, the animal's head is restrained as the external nares are cleaned with a disposable cloth. This minimizes any contaminating organisms. Secondly, the length of insertion is estimated using the distance from the nares to the medial canthus of the eye. Next, a double-guarded culture swab is pushed into the nose along the ventral meatus to the estimated region, which is the nasopharynx. Pressure is placed downwards by advancing to allow easy passage. The guarded culture is then retracted 2 inches. This allows the polyvinyl chloride or PVC swab sheath to be pushed through the PVC. Then the actual swab can be pushed through. This swab is then rotated several times, left in place for a few seconds, then withdrawn. Lastly, the top of the swab is broken off, placed in transport media, labelled, and transported to the appropriate location.
Transtracheal wash is another technique that can obtain samples from deep lungs. The advantages of using this technique is that samples from lower respiratory tract can be obtained with lower risk of contamination. However, this technique is time-consuming, and it is an invasive procedure with risk of bacterial and virus infection. To perform this sampling technique, firstly, sedation and halter is necessary to restrain the animal. Then, clipping and surgically preparing the sites, which locates halfway between the larynx, is necessary. After that, infiltrate the selected puncture sites with 2 to 5 ml of 2% lidocaine. After that, insert the needle or catheter trocar on the ventral midline. Inject the sterile saline through the catheter into the trachea. Aspirate and recover at least 3 to 5 ml of the fluid, and collect the specimen in a sterile labeled container. Last but not least, bronchoalveolar lavage can also be used as a sampling technique. The advantages of using such techniques is able to obtain samples from deep lungs. However, it has a high risk of contamination of mucus from trachea. It may also develop complications if not done properly, for example, pneumothorax, collapsed airway, or damaging trachea. To perform this technique, the animal is needed to put under anesthesia. Insert the trachea tube into airway and select a lung lobe for sample collection. The tube should sit perfectly in the small bronchus. Connect the trachea tube with a bottle of 5 ml per kilo body weight, warm sterile saline and a 35 ml syringe using a T adapter. Instill the saline into the trachea tube and wait for a couple of seconds. Lastly, gently suck up the saline using the syringe until no fluid is obtained.
The appropriate PPE and decontamination procedures will always vary depending on the situation based on clinical signs and presentation. Veterinary standard precautions should be implemented to reduce the risk of sample contamination and possible transmission via physical contact, droplets, and inhalation of airborne pathogens. Hand hygiene is the most effective way to prevent the spread of infection. It should always be performed before and after each procedure to minimize the chances of sample contamination. PPE is required especially when in contact with animals' blood, body substances, mucous membranes, or non-intact skin. PPE includes disposable gloves, face protection such as surgical mask and goggles, or a full face shield or respirator. Footwear such as disposable shoe covers in a clinic and washable rubber boots during field visits, and disposable gowns or overalls. All specimens must be presumed to be infectious. Protective outerwear and disposable gloves must be worn. The risk and protection levels determine the appropriate PPE and decontamination procedures. The low risk level involves minimal exposure to infectious materials, therefore only requires personal hygiene measures, overalls, and boots. The variable risk level involves potential exposure to infectious materials, which require appropriate PPE and decontamination, and may require the use of overalls, boots, and disposable gloves. The high risk level involves potential exposure to infectious materials
of a dangerous zoonotic disease. Hence, we require a higher level of PPE and decontamination.
We will now move on to our unknown organism cases, from number 19 to 24.
Case 19 was investigated by Kotasek and Tori Kitschke. It was presented as a swab from a transtracheal wash of a young coughing foal. The organism we found responsible was Rhodococcus equi. Our clinical syndrome was characterised by increased respiration rate and effort, dyspnea, cough, nasal discharge, or a fever, lethargy, or anorexia in a dry coat. Also, a failure to thrive or hearing crackles and wheezes on auscultation. Bronchopneumonia could be present, along with ulcerative enterocolitis. The differential diagnosis list that we came up with was Rhodococcus equi, also known as rattles, 3 different strains of Streptococcus, or, if involved with mixed infections, could be Staphylococcus or E. coli.
Day 1 showed us that there was no growth on the McConkey agar, no hemolysis on the sheep's blood agar, and the gram stain showed a gram-positive bacteria. But does it look like rods or cocci? After having a closer look, although it appears to be cocci on first glance, when we zoomed in on selected bacteria, such as this one, you can see that it appears longer than it is wide, indicating our unknown bacteria was a pleomorphic rod, which can appear as a coccus. With this information, along with our positive coagulase and catalase tests that we were given on day 2, we were able to rule out E. coli, as it is a gram-negative bacteria, and Streptococcus species, as there was no hemolysis on the blood agar. To cover all our bases, we didn't rule out Staph species just yet, even though Staph are cocci. Day 3 gave us our next set of biochemical tests, which indicated that our bacteria was not able to ferment sugar. This allowed us to rule out Staph. Finally, a CAMP test and nitrate fermenting test were undertaken, both yielding positive results, definitively allowing us to identify Rhodococcus equi as the cause of our foal's cough. Although in vitro the bacteria is susceptible to many antibiotics, most are unable to penetrate the abscesses in vivo. Therefore, treatment is limited to lipophilic antimicrobials, usually long-course combination rifampin, which is an anti-tuberculosis drug, and erythromycin, which is a macrolide. 2 other macrolides, azithromycin and clarithromycin, have recently been approved for use in animals and are associated with less side effects than erythromycin. It is not recommended to use a single-agent macrolide or single-agent rifampin, and this practice has been associated with the development of antimicrobial resistance. Using the combination treatment reduces this risk. Additional supportive therapy for the foal is recommended, such as rehydration, bronchodilation, and expectorants to aid in recovery. Some properties practice prophylactic antibiotic treatment. However, this is associated with mixed results and links to antibiotic resistance, and therefore should be avoided. Rehip, which is Rhodococcus equi hyperimmune plasma, has also shown promise, and 2 litres can be infused prophylactically in foals if they are under 36 hours old.
The most effective control measure is environmental management. Rhodococcus equi is a soil saprophyte, so dusty conditions, dusty bedding and stocking rates should be minimised, while pasture, irrigation and ventilation maintained to decrease the risk of any aerosol transmission. Any equine feces fertiliser used on the property must be heat treated prior to application. Husbandry is imperative to control bacterial outbreaks, including thoroughly cleaning and disinfecting stables and separating sick foals.
So this is Brie and Hannah here, and we had case 20, which was a swab from a bronchoalveolar lavage of a Burmese cat with a history of coughing. So we expected pneumonia, for which the clinical signs are fever, coughing, sneezing, oculonasal discharge, breathing difficulties, and inappetence. A number of pathogenic bacteria and commensals can cause pneumonia in cats, so our differential diagnoses was ruled down to Pasteurella multisida, Mycoplasma felis, Chlamydophilia psittaci or Chlamydophila felis, Bordetella bronchoseptica, Streptococcus canis or pneumoniae, and Staphylococcal aureus. So on day 1, we received our gram stain, which showed small gram-negative rods that were a bit coccobacillary, and we had lactose-negative growth on McConkey agar and growth on blood agar in 48 hours with small, convex, smooth colonies. On day 2, we requested the oxidase test, which you can see turned out positive next to the control there. So on day 3, we requested a few tests. The nitrate reduction test was positive, indicating the presence of the nitroreductase enzyme. Then we had a positive urease result, so we knew our organism could utilise urea. And then finally, our organism was unreactive for the oxidation fermentation test, so we know it cannot utilise glucose.
So this is just a flowchart depicting the thought processes and how we got to our final differential. So the gram stain and morphology is where we first started, and we had gram-negative rods. So already that eliminated 3 of our differential diagnoses, which were all within the gram-positive. And that just left us with Pasteurella, Bordetella, and Chlamydia species. Our sheep blood agar, we did have some growth after 24 hours of incubation with no hemolysis or gamma hemolysis. So that already ruled out the Chlamydia species, as that doesn't grow on agar. Our McConkey agar, we had growth present, but it was negative for lactose fermentation. So that's when we conducted an oxidative test. And then from there, the only organism left on our differential list was Bordetella bronchoseptica. But based off the dichotomous key, we needed to confirm that it wasn't Eromonas, Pseudomonas, Burkholderia, or some kind of other Bordetella species. So we conducted an oxidative fermentation test. We had absolutely no reaction, so that confirmed that it definitely was the Bordetella species that we were dealing with. So we conducted a urea test, and it confirmed again that it's definitely Bordetella, but all Bordetella are positive for urea. So to narrow it down and ensure it was definitely Bordetella bronchoseptica that we were dealing with, a nitrate test was conducted, which came back as positive, so that ruled out any chance of it being Bordetella avium or Bordetella pertussis, and left us with our final organism. For the antibiotic susceptibility testing, it was found that the only antibiotic that our organism was resistant to was penicillin. So in terms of treating this cat in particular, we know we can't use penicillin because even though it's a first-line antibiotic, our organism is resistant to it. So we would opt for amoxicillin clavulinate as it's a second-line antibiotic. According to the literature, where sensitivity cultures aren't performed, tetracycline is recommended, and it is really important that infected animals are isolated until their clinical signs resolve, just because the disease is really contagious. For those severe cases, we can also offer supportive therapy, so things like cough suppressants like Linctol syrup or codeine, bronchodilators, corticosteroids to reduce inflammation, bearing in mind we can't use non-steroidals along with that, so meloxicam would be off the cards. Humidification and fluid therapy can also be offered, and intensive nursing care.
Case number 21 of Group 4 was given to Kimberley, Landis and Christy Lang to investigate. Clinical history: a swab from the bronchi of a young dairy calf with pneumonia that died following a bout of dyspnea. To begin our investigation, Kimberley and I put together a list of potential causative agents that are responsible for bacterial pneumonia. The differential diagnosis list includes 4 pathogens that are involved in the bovine respiratory disease complex, or BRDC, is a term applied to a group of respiratory diseases that involve a variety of viral and bacterial pathogens. The bacterial agents act jointly and cause a variety of respiratory diseases in cattle and other ruminants, including pneumonia in young calves, which can be fatal. The bacterial organisms include Mannheima hemolytica, which is considered the most common and serious of all the bacterial agents. Also involved in the complex is Pasteurella multicida, Mycoplasma bovis, and Histophilus somni. Other potential organisms that could be responsible for bacterial pneumonia in young calves include Bibersteiner torosi, a genus of bacteria that has been associated with respiratory diseases in ruminants, and lastly, botulism, Clostridium botulinum, which is a rapid onset, usually fatal disease caused by the botulinum toxin produced by the bacterium Clostridium botulinum. Given the sudden death of the calf, we could not rule this one out from our potential diagnosis. Following the clinical history, the farmer has not provided any further symptoms prior to the calf's death. Broadly speaking, clinical signs to be aware of in bacterial pneumonia include varying degrees of depression and loss of interest in surroundings, fever and lethargy and unwillingness to move, discharge from eyes, nose and mouth, and often a moist cough accompanies the condition, and in this case, dyspnea, which is rapid, slow breathing.
The morphology of our unknown organism was gram-negative, small, encapsulated, and coccobacillus in shape. To determine our unknown organism that caused a young dairy calf to die from pneumonia, we first came up with a potential list of bacteria. From here, the unknown organism was plated onto sheep blood agar and McConkey agar. Sheep blood agar came back with growth, and so we concluded that it was gamma hemolysis. However, McConkey agar had no growth. A gram stain was then undertaken, which provided us with the information that it was gram-negative, small encapsulated rods and coccobacillus in shape. This allowed us to determine that the potential bacteria was either Pasteurella multicidia or Histophilus somnii. To differentiate between these two bacteria, we required a catalase and oxidase test. Both catalase and oxidase came back as positive, and so the species was identified to be Pasteurella multicidia. However, as Pasteurella multicidia has many different subspecies, we required further testing to differentiate these species. A trehalose and sorbitol test were then undertaken. Trehalose came back positive and sorbitol came back negative, which allowed us to come to the final diagnosis that our unknown organism was Pasteurella multicidia, subspecies multicidia. Pasteurella also seemed to be sensitive to all antibiotics. For treatment and control, the treatment requires antimicrobial therapy and is most effective at the early febrile stage. Typically, amoxicillin clavulinate, a beta-lactamase inhibitor and penicillin combination, is the preferred treatment in cattle as the organism is susceptible to penicillin. However, tetracyclines is also a popular antimicrobial choice. Current vaccines are available for the control of the disease, and they contain either an inactivated bacteria or a live attenuated bacteria.
As for case 22, we have obtained a swab from the trachea of a young steer that developed pneumonia after entry into a feedlot. As for the clinical signs of the steer, it includes pneumonia, sudden onset fever, depression, anorexia, tachypnea, serious nasal discharge, dehydration, sunken eyes, and extended skin tan duration. As for the differential diagnosis of this case, we have included Mannheimia hemolytica, Pasteurella multocida, Histophilus somni, Mycoplasma bovis, Chlamydia picorum, Mycobacterium bovis, Streptococcus suis, Archaeobacterium pyogenes, and Pseudomonas aeruginosa. Day 1, when we obtained the sample, we have did a bacterial culture on sheep blood agar plate, McConkey agar plate, and chocolate agar plate. We have also did a gram stain on the bacteria as well. On the sheep blood agar plate, we can see growth with hemolysis. On the McConkey agar plate, we can see growth with lactose positive. As for chocolate agar plate, there's no difference in growth is observed. As for gram stain, a pink color indicating gram-negative bacilli is observed. After the tests done on day 1, a number of differential diagnoses is eliminated, leaving 2 possible bacteria, Mannheimia hemolytica and Pseudomonas aeruginosa. On day 2, we have done a number of tests, including oxidase test, urea test, ornithine test, antibiotic susceptibility test, indole test, and maltol test. Upon all tests, only maltol test can help to differentiate between the 2 bacteria, and it shows positive in our results. And with all the tests we have done in day 1 and day 2, we are able to conclude that the steer was infected with bacteria called Mannheimia hemolytica. Mannheimia hemolytica is commensal of the nasopharynx. A1 and A6 are the most common isolates from pneumonia in cows. It is an opportunist which gain access when host defense is compromised by stress or respiratory viruses or mycoplasma infection. Virulence factors include adhesins, which facilitates adherence to the respiratory tract, leukotoxin, which has potent effects on ruminant neutrophils, which impair the mitochondrial function, leading to cell death. Capsule inhibits complement cascade activation and endotoxin, which also evolve leukocyte function.
According to our antimicrobial sensitivity results, the organism is sensitive to all tested antibiotics, which includes penicillin, amoxiclav, chloramphenicol, tetracycline, TMS, gentamicin, and enrofloxacin. Our primary treatment would be using antibiotics and anti-inflammatory drugs. We would recommend the use of penicillin in the early febrile stage of the disease. In the later stage of the disease, we would recommend the use of oxytetracycline, which should be administered as an IM injection at 10 mg per kg per day for the non-long-acting product. It has a withholding period of 14 days. The treatment should persist for 4 to 5 days or at least 24 to 48 hours after the temperature returns back to normal. The alternatives are tulathromycin, florfenicol, and ceftiofur. However, the alternatives could be more expensive. In order to control the disease, we should aim to minimize the stress to which calves are exposed, especially during transportation, introduction into feedlots, weather changes, and sale yards. Besides vaccinating the animals at least 3 weeks prior to transportation had been shown to be effective. It is recommended to purchase stock from producers with a quality assurance program. In the face of an outbreak, administration of antibiotics to in-contact, at-risk groups of animals should ideally be done by injection. It is also very important to isolate the infected animals and commence early treatment.
Pleuropneumonia refers to the infection of the lungs with additional inflammation of the pleura. In cases of swine, the disease is caused by the bacterium Actinobacillus pleuropneumoniae and is more commonly known as APP. Pigs are usually infected by aerosols from previously acutely infected pigs which now act as carriers, exacerbated by poor environmental conditions such as overstocking, poor ventilation, stress, or co-infection with other respiratory pathogens. 3 forms of the condition exist. In the peracute form, clinical signs include dog-sitting position, severe dyspnea, loss of appetite, pyrexia, lethargy or collapse when moving, and blood-stained discharge from the nose and mouth. Pigs with this form of the infection will die within 24 to 48 hours from endotoxic shock. In the acute form, clinical signs are much less rapid, with lethargy, dyspnea, and the occasional cough accompanied with lack of appetite for a few days prior to either death, which is true in 20 to 80% of cases, full recovery, or the transition to the chronic form. The chronic form includes permanent depressed growth and a permanent cough as well. These clinical signs are primarily the result of hemolysin and other toxins produced by the bacteria, which cause necrosis of pulmonary endothelial cells and macrophages, while simultaneously causing vasculitis in the lungs, leading to a thrombosis or clot, which results in infarction. Activating a rapid immune response to sequester the infarcts of the lungs results in inflammation of the pleura and of the lungs.
The chronic form of this infection involves consolidation of the lung tissue, which is thicker with adhesions, growth retardation, coughing, and pneumonia.
On our differential diagnosis list, we included organisms that could cause respiratory distress to swine and the opportunity for hemorrhaging fluid around the lungs. Bordetella bronchoseptica, Mycoplasma hyphaneumoniae, Pasteurella multisida, Glasturella australis, Haemophila parasuis, and Streptococcus suis were all included as plausible causative agents for this infection. To identify the specific pathogen causing this infection from our differential diagnosis list, we performed a gram stain on day 1. This gram stain resulted in a gram-negative bacillus, eliminating Streptococcus suis and Mycoplasma hyphaneumoniae as they were both gram-positive organisms. We also prepared a sheep blood agar, a McConkey agar, and a chocolate blood agar, allowing them to incubate overnight. On day 2, these results from the agars were ready to be interpreted. On the sheep blood agar, we had greyish-white colonies with alpha hemolysis at incubation for 37 degrees for 24 hours. On the McConkey agar, we had no growth. And on the chocolate blood agar, we had enhanced growth when the chocolate agar was incubated under carbon dioxide. This also once again eliminated Mycoplasma hyphaneumoniae, being an aerobic organism, it would not have incubated better under conditions of enhanced CO2. This also eliminated Bordetella bronchoseptica, as it was lactose negative on McConkey agar, but our McConkey agar had no growth. It is worth noting as well that Actinobacillus pleuropneumoniae is one of the few Actinobacillus organisms that does not grow on McConkey agar. At the end of day 2, based upon our agars, we requested 4 different biochemical tests, including an oxidase test, an indole test, a urease test, and a CAMP test. On day 3, these were available and we were ready to perform them. The oxidase test resulted in an organism which was oxidase positive. This did not add to our knowledge base, as organisms that don't grow on McConkey agar are typically oxidase positive. On our indole test, we got negative, which eliminated Pastorella multicida. On our urease test, we got positive, which eliminated Pastorella multicida, Haemophila parasuis, and Glyceria australis. They were all urease negative. On our CAMP test, we got positive, which once again eliminated Pastorella multicida, Haemophila parasuis, and Glyceria australis, which were all CAMP negative. Based upon these tests, the only organism that it could be was Actinobacillus pleuropneumoniae. On day 4, we performed an antimicrobial susceptibility test and visualised them. We found that there was no resistance and that it was susceptible to all antimicrobials tested.
From our antibiotic susceptibility testing, Actinobacillus pleuropneumoniae is susceptible to penicillin, tetracycline, chlorophenicol, amoxicillin clavinate, sulfonamide trimethoprim, gentamicin, and amrofloxacin. However, in Australia, the use of chloromethophenicol, gentamicin, and enrofloxacin, which is a fluoroquinolone, are prohibited for the use of pigs. Additionally, it is noticed on the slide that as the organism is susceptible to chlorophenicol, there is also a susceptibility to fluorophenocal. As the organism is susceptible to a variety of first and second line antibiotics, first line antibiotics are preferred, such as penicillin and tetracyclines. Additionally, macrolides such as tilamicin are commonly used to treat infections by this organism. However, this was not tested in the antibiotic susceptibility test play. Additionally, fluorophenocal can also be used to treat the infection. Antibiotics are usually effective in the early stages of clinically infected pigs. This can be done by injection of peritoneal antibiotics in animals that are not eating and drinking. The more effective use of antibiotics occurs in the feed and water. This must be monitored and carefully administered as resistance can occur. Another control mechanism is the Swiss parcel depopulation technique. In this technique, the pigs are sold off except for the sows. The sows are then medicated with their antibiotic. Then the sheds are completely cleaned. This thereby eliminates carrier animals, treats sows, and eliminates any organisms in the environment. Prevention mechanisms are a more effective way to control the disease. This can include vaccinations which are serotype specific, aerosol disinfection that are safe for animal use, age segregation weaning, and minimizing stress factors such as mixing and transportation.
Unknown case 24 was a swab from the fluid drained from the chest cavity of a dog with pleural effusion. This case is an example of a respiratory infection, and the case was done by Chloe and Erin. Nocardia, particularly Nocardia asteroides, commonly causes pyothorax in dogs when it gains entrance into the thoracic cavity. The pathogen can gain entry via inhalation, bite wounds which penetrate the thorax, and migration of foreign bodies such as grass seeds that rupture underlying pulmonary tissue. Once the bacteria is in the thorax, an inflammatory immune response occurs where neutrophils and eosinophils try to remove the antigen. However, as these cells fail to remove the antigen, they form septic exudate within the cavity, which triggers the body to wall off the infection by forming a pyogranuloma. Nocardia commonly causes pyogranulomatous infections as it stimulates chronic inflammatory processes due to inflammatory cells failing to remove said bacteria. Nocardia evades these inflammatory cells by inhibiting fusion of the phagosome and lysosome in phagocytes. Pyothorax leads to an abnormal accumulation of fluid in the pleural space, resulting in pleural effusion. Although pleural effusion occurs as a result of pyothorax, it may commonly be merely secondary to other abnormalities such as heartworm, periodontitis, cranial vena cava obstruction, trauma, pancreatitis, and more. This disease affects the respiratory and cardiovascular system and can present in the following clinical signs: respiratory difficulty, open mouth breathing, cyanosis, lethargy, cough, rapid breathing, shortness of breath, lack of appetite, anorexia, and fever. For this case, our differential diagnosis list included Nocardia asteroides, Mycobacterium tuberculosis, Mycobacterium bovis, Mycobacterium canissae, Actinomyces, Streptococcus equi, Streptococcus canis, E. coli, and Pasteurella.
Here is our overall diagram of how we came to our final diagnosis of Nocardia, and it shows all the tests that we ran. On day 1, we received our gram stain and our results for growth on McConkey and sheep blood agar. The findings showed that our bacteria stained gram positive, and they were rods and they were filamentous. And our organism grew on sheep blood agar but did not grow on McConkey agar. These findings allowed us to rule out some organisms from our differentials list, and they're shown in red on the slide. And this led us to believe that it could be Nocardia, Mycobacterium, or Dermatophilus. We then requested further testing. We requested a Zilneyson stain, a modified Zilneyson stain, and growth on Sabrid agar. When we received our tests back, we found that our organism was modified Zilneyson positive as it stained a reddish colour. We also found that it was Zilneyson negative as it stained blue. If it stained red, this would have suggested that it was Mycobacteria. And our organism also grew on Sabrid agar. Nocardia was the only organism that would grow on Sabrid agar, so a combination of these results gave us our final identification of Nocardia. Our antimicrobial susceptibility results showed that our organism was sensitive to all antibiotics except clindamycin, which it was resistant to. And we will see in the next slide that the antimicrobials of choice are sulfonamide and trimethoprim. Treatment is a combination of antimicrobials and surgical intervention. Surgery to drain the thorax of septic fluid, remove any foreign particles, and to implement a thoracostomy drain is the first step in treatment. Surgery is vital as it reduces the chance of recurring infection. The thoracostomy drain is used to drain septic material and debris and lavage the pleural space with 10 to 20 ml per kilo of 0.9% saline 3 to 4 times per day. Nocardia is sensitive to multiple antimicrobials, but the most recommended antimicrobial treatment is 6 weeks minimum of sulfonamide and trimethoprim due to the pyogranulomatous chronic nature of the infection. It is also recommended that antimicrobial treatment is continued for a further 2 weeks after no abnormalities are seen upon a radiograph of the thorax. As previously mentioned, the Nocardia appeared to be sensitive to all antimicrobials except clindamycin. There are currently no vaccines available for Nocardia.
That's all from us. Thanks for listening.